Hello, and welcome to our webinar series, Candid Conversations on Health. Throughout the year, we will tackle a variety of topics related to our health and wellness. The focus of today's webinar is colorectal cancer awareness. My name is Ayana Usri, and I am the support coordinator for the Louisiana Department of Health's Bureau of Community Partnerships and Health Equity. The Bureau of Community Partnerships and Health Equity is devoted to increasing the citizens of Louisiana's knowledge about what affects our health, especially for those in particularly vulnerable communities and populations. This devotion is rooted in raising awareness through webinars like today's and partnering with stakeholders in the community to move toward a healthier Louisiana. At this time, it is my honor to introduce Dr. Courtney N. Phillips, Secretary of the Louisiana Department of Health, who will share a few welcoming words. Dr. Phillips?
Thank you, Ms. Usuri. And good evening, and thank you, everyone. And thank y'all for joining our colorectal cancer awareness webinar. First, let me start off by thanking the Bureau of Community Partnerships and Health Equity for hosting this series and trying to draw attention to this very important topic. Also, thank you to our moderator and panelists for joining us today and taking time out of their schedule to share this very helpful information that I know that they are all very passionate about. As you all know, in November, the department released their business plan, and one of the priorities outlined was the reduction of colorectal cancer and increasing the screenings. We know that colorectal cancer is one of the most preventable, one of the most treatable, and one of the most survivable cancers there is. But yet, Louisiana's rates still fall behind the national average. Our state ranks 4th highest in the United States in terms of death as a result of colorectal cancer. That's behind Mississippi, West Virginia, and Oklahoma. And we start to talk about the disparities across the state, we know that Black residents in Louisiana and also our rural communities have a higher overall incidence rate. We also know that they have a higher rate in terms of death as a result of colorectal cancer. This is because oftentimes of the screening rates. Louisiana has work to do in terms of our screening. That's why we're partnering with several entities across the state, including Taking Aim Against Cancer in Louisiana, the Mary Bird Perkins Center, Our Lady of the Lake Hospital, as well as Ochsner Health System. Working with these entities and forming these partnerships will provide community screening events statewide at no cost, no out-of-pocket cost for residents. We want the individuals of Louisiana to know that we're making early detection more accessible and that screenings are not limited to colonoscopies. We know in conversation that many folks are intimidated by colonoscopies. They sometimes feel embarrassed, uncomfortable, but there are many ways to be screened, and you'll learn about that today, including some of the tests that you can do in the privacy of your home. We want to make sure that anyone between the ages of 45 and 75, or if you're at high risk, we want to make sure that you have a plan to get screened. We want to be a resource for you. And I'm excited about this webinar and our panelists to share more information with you today. So thank you for having me. And Ms. Ayana, I'm going to turn it back over to you.
Wonderful. Thank you so much, Secretary Phillips. Now, I'll provide a brief outline of today's events, as well as introduce our facts about colorectal cancer awareness. So here's our overview for today's events. We're going to start with our intro welcome, which we're doing right now. Then we'll go over the facts as it relates to colorectal cancer awareness. We'll have our panel discussion, and then we'll follow up on those key takeaways. So our facts related to colorectal cancer awareness. So first, information. Get up-to-date and accurate information from credible sources related to colorectal cancer. 2, screening. Everyone between the ages of 45 and 75 should get screened for colorectal cancer. 3, prevention. Understanding what colorectal cancer is, the screening recommendations, and risk factors associated with colorectal cancer. And then 4, last but not least, early detection saves lives. These 4 facts, information, screening, prevention, and early detection saves lives, are ones you will hear throughout our webinar today. I want to stress the importance of getting information from trustworthy sources so that if you are going to share colorectal cancer information with loved ones or within your community, please use only information coming from websites like the Louisiana Department of Health, the CDC, the American Cancer Society, and the like. We also will provide you with a one-pager via email after this session to aid you in how to share colorectal cancer information. Sharing accurate information can help save lives. And now it is my pleasure to introduce the Director of the Bureau of Community Partnerships and Health Equity, Devondra Brown.
Well, thank you, Ms. Ussery, and thank you, Secretary Phillips, both of you for the warm welcomes today. And thank each one of you for joining our candid conversations on health. Today's is colorectal cancer awareness. Before I turn the session over to our event moderator, I just want to express the gratitude of attending today's event. I hope that you find today's discussion informative and helpful. All of our panelists will answer questions that were previously submitted and really have a deep discussion on colorectal awareness. So let me introduce our moderator for today, Dr. Rodney Anthony. Dr. Anthony, originally from Woodville, Mississippi, attended Alcorn State University for undergraduate studies and obtained a Bachelor's of Science in Biology. He then attended Jackson State University to complete his Master of Public Health degree with concentration in health policy and management. Lastly, he attended Nova Southeastern University, where he obtained a Doctor of Health Science degree. Rodney began his public health career at the Mississippi State Department of Health, where he assisted small towns and cities achieve a health city environment as defined by MSDH and the CDC. He began employment at the Louisiana Department of Health in 2014, and during his tenure, he occupied an array of roles, including working with the Developmental Disability Service System, assisting in leading advocacy efforts at the Developmental Disabilities Council, and lastly, leading the cancer policy and prevention programs, which included collaborating with outside entities like Taking Aim at Cancer in Louisiana, which is TACL, before leaving at the end of 2021. Currently, Rodney is the Community Education Manager at Women's Hospital, leading their public-facing educational programs that focuses on the services provided that impact women and infant health in the Metro Baton Rouge area. So it is my pleasure to turn the stage over to my friend and colleague, Dr. Rodney Anthony. Sir, the floor is yours.
Thank you. So thank you, Secretary Phillips, Mrs. Brown, and Ms. Ussery for starting today's event. I know right now, just to get started, that I have a little delay in my video, so work with me, but let's kick it off. So for each of you, the community members, stakeholders who took out the time of your very busy schedule to attend this important discussion, thank you. In this webinar, our hope is that what you hear, you find useful, empowering, and encouraging. We want you, the audience, to leave this conversation empowered with the knowledge to know the signs, symptoms, and risk factors of colorectal cancer, as well as what you should do to get screened for colorectal cancer and what treatment options may be available. We have trusted gatekeepers from around the state that would lead and be a part of this discussion. But before we go any further, let me do a brief introduction of our panelists. Dr. Denisha Clayton. She joined Ochsner Medical Center, Baton Rouge in September of 2020. She received her undergraduate degree in biological sciences from the Louisiana State University. She then earned a medical degree from Louisiana State University Health Sciences Center in New Orleans. After obtaining her medical degree, Dr. Clayton completed her internship and residency in internal medicine at the Mayo Clinic, Jacksonville. She then went on to complete her gastroenterology and hepatology fellowship at Tulane University School of Medicine. Dr. Clayton has been involved in several leadership positions throughout her academic career, and she hopes to continue to expand her leadership roles at Ochsner Medical Center, New Baton Rouge. Dr. Clayton is board certified by the American Board of Internal Medicine and Gastroenterology. Her clinical interests are general gastroenterology, and her interests outside of medicine includes traveling, reading, cooking, and spending time with her family. Next, we have Mrs. Renee Austin Duffin. She's an accomplished and proven leader in the private sector and government. Renee earned her BS degree in business and public administration from LSU in 1987 and a Master of Public Administration from Southern University in 1989. Renee worked for the state for 13 years in both the legislative and executive branches. From 1996 to 2001, Renee served in Governor Mike Foster's administration as the first at first, the Undersecretary of the Department of Social Services, then Deputy Commissioner of Administration, and lastly, the Secretary of the Department of Social Services during his second term. Renee served as a Senior Vice President for Member and Community Relations at Blue Cross and Blue Shield of Louisiana in November of 2001 through 2006. Renee became the Vice President of Cancer Support and Outreach at Mary Bird Perkins Cancer Center in February of 2007. Since then, she's been responsible for programs that include education, research and early detection, including the management of 2 mobile medical clinics, grants management, which has a portfolio in excess of $3 million, as well as governmental affairs liaison for the Cancer Center at local, state, and the federal level. Next, we have Dr. Keith Winfrey. He's the Chief Medical Officer at the New Orleans East Louisiana Community Health Center, known as NOELA, and an adjunct professor of medicine at Tulane University School of Medicine. He completed his residency training in internal medicine and a preventive medicine fellowship at Tulane University School of Medicine. Dr. Winfrey also has a master's degree in health system management from the Tulane University School of Public Health and Tropical Medicine. Dr. Winfrey's Health Center, NOELA Community Health Center, has been recognized nationally for raising its colorectal cancer screening rates from 3% in 2012 to 80% in 2018. In 2019, the NOELA Community Health Center was selected as a grand prize recipient for the National Colorectal Cancer Roundtable's 80% by 2018 National Achievement Award. And Dr. Winfrey was awarded the Cancer Community's inaugural Catalyst for Change Award, an award that recognizes individuals for significantly improving access to cancer care by bringing scientific advancements in cancer care and treatment to underserved populations. In addition to his work at the NOELA CHC, Dr. Winfrey serves on the steering committee for the National Colorectal Cancer Roundtable, the Louisiana Colorectal Cancer Roundtable, and the Taking Aim at Cancer in Louisiana's clinical committee. Recently, in 2020, Dr. Winfrey had the honor to share his expertise and experience during the President's Cancer Panel, Improving Resilience and Equity in Cancer Screening meeting. Lastly, we have Dr. Chancellor Donald. He's originally from Gretna, Florida, and attended Florida A&M University for his undergraduate studies and graduated magna cum laude. He then attended the University of Miami School of Medicine for his medical degree. He completed his internship, residency, and fellowship at Tulane University. He was selected as the chief resident and chief fellow during his training. Dr. Donald currently has board certifications in internal medicine, hematology, and medical oncology. Dr. Donald holds the positions of assistant professor for clinical medicine at Tulane University. His academic focus is advocacy and health disparities regarding patients with hematologic disorders and malignancy. Dr. Donald volunteers his time to Taking Aim at Cancer in Louisiana, where he serves as the chief medical officer. Dr. Donald provides insight that helps drive the direction of tackle strategic initiatives to combat the low screening rates of breast and colorectal cancers experienced in the state of Louisiana. So these are our panelists. They're going to help us to have a brief or deeper discussion. As we start this panel discussion, it is important that we remain vigilant in the fight against diseases like cancer, pursuing a healthier Louisiana. This discussion will be factual, based in science and understanding. Let me be the first to say, as the moderator of this session, that people have the right to feel what they feel regarding their past and present experiences of racism, sexism, mistreatment, or injustice. We know that these experiences play a part in people, populations, and communities' trust in the healthcare system. So with that, let's get the panel discussion started. My first question is to all of the panelists. What is your profession and how is it related to colorectal cancer? we can kick it off with Ms. Duffin.
Good afternoon. As the Vice President for Cancer Support and Outreach at Maryburg Perkins, my role is to help to educate the community about the importance of prevention, as well as early detection of preventable cancers and screening accessible cancers, of which colorectal cancer is screening accessible. As Dr. Phillips stated earlier, it is a totally beatable cancer if caught early. So our role here at Maryburg Perkins is to go out into the community and reach those that are underserved, uninsured, underinsured, as well as the insured, not only with education, but also screening accessible services to ensure that they are getting those necessary and being compliant with getting screened for colorectal cancer.
Thank you. Dr. Clayton?
Unmuted. Good afternoon. So I am by trade a gastroenterologist, and so I come into this picture by the screening part of colorectal cancer. So we will get in a deeper discussion. There are more than one ways to screen for colon cancer, but I perform colonoscopies, which I consider as the gold standard because it's both diagnostic and therapeutic. And like Renee said earlier, colon cancer is very preventable, and we can start this fight, with colonoscopies.
Thank you. Next, we'll go to Dr. Winfrey.
Yeah, good afternoon, and thanks for having me on the panel. I'm a primary care provider here in the New Orleans area, and so my role is to serve as the initial entry point into healthcare. So for those patients who are trying to navigate the healthcare system, wanting to know where to start in terms of improving their health, they tend to come to primary care providers. We're actually located in an underserved area in New Orleans, area that tends to have less access to care historically. And so we are here basically to be a beacon for the uninsured community, those who have difficulty finding access to healthcare, or those who just don't know where to start. And so once you come to us as a primary care provider, we sit down with patients and help them understand their risk factors for cancers. We look at their family history, we look at lifestyle factors, other chronic diseases, and really help them to understand their risk, and then explain to them and go over with them the different types of screening tests that are available to assist them in understanding whether they have cancer or not.
Thank you. And Dr. Donald?
Again, it's great to be on a great panel with great panelists. And thank you, Dr. Anthony, for that generous introduction. I'm a medical oncologist. So as far as my role, I actually treat the patients once they are diagnosed with cancer. And once we get past the diagnosis, we go to a surveillance phase for the monitoring for recurrence of malignancy. Of course, there's management of the chemotherapy as well as other modalities we may use as well. Happy to be here.
Thank you. And with that, I'll kick the first question to you, Dr. Donald. What is colorectal cancer, and does it affect just your colon?
So let's just start very broadly. When we say cancer, we've heard a lot of words with that: tumors, growth, mass. But when we talk about true malignancy, which is most implied when you say the word cancer, we're talking about a part of the body that abnormally grows, and then from there has the ability to invade structures that are around it, and then ultimately the ability to break away from that original structure and move to other parts of the body. So cancer would be defined in this setting as a true malignancy with invasive and metastatic potential. In regards to if it just affects the organ that is the colon, the answer is no. Often we can detect early signs of colon cancer by doing blood work and noting anemia. That's one of the standard things that we look for. We want to ensure that our patients are screened if they are of a certain age for colorectal cancer if we have an iron deficiency anemia. Additionally, when we think about the colon, we think about bowel movements. We certainly can have abdominal pain, weight loss, and other what we call general constitutional symptoms that will result from colorectal cancer.
Thank you. And your response rolls right into my next question for Dr. Clayton. Is colorectal cancer preventable? If so, how?
Absolutely. And so just piggybacking a little bit off of Dr. Donald, colon cancer surprisingly is like the third most common cancer in the United States, and then the third cause of cancer-related deaths in the United States, which is unfortunate because it's highly preventable. So there are a few modalities that we have in place to screen for colon cancer. And let me just start. The guidelines now, as of May of last year, is that we screen every adult starting at age 45 for colon cancer. There are some invasive and non-invasive methods. One, I'll start with colonoscopy because everybody hears about a colonoscopy. The colonoscopy is an invasive procedure. It's only 20 minutes, but it's the gold standard because if you have polyps, which are precancerous growths in your colon, they can turn to colon cancer. We can both see the polyp at the time of the procedure and remove the polyp while we're there. But if, a patient does not want a procedure such as a colonoscopy, we do have stool-based tests that we could apply that they can do in the comfort of their home and return the sample back to their doctor. And that's something that they can do. It ranges from annually to every 3 years, depending on the type of stool-based test that they receive. And then we also have a CT scan or a CT colonography test that we can incorporate as well to screen for colon cancer. Now, with that being said, both the stool-based test and the CT colonography, if they both turn back positive, then the patient would have to ultimately get a colonoscopy because, like I said, we need to be able to actually see inside the colon and look for polyps or look for cancer with the colonoscopy.
Great. Thank you. So the next question I wrote to Dr. Winfrey: what racial/ethnic groups are at an increased risk for developing colorectal cancer?
Sure. So we know that everyone potentially can develop colorectal cancer. So it is important that everyone understands their particular risk factors that are associated with it. But the data shows us that African Americans and Blacks tend to have the highest rates of both colorectal cancer, being diagnosed with colorectal cancer, and dying from colorectal cancer. We know that incidence rates can be as high as 20% higher in Blacks than in whites. It can also be 50% higher in Blacks than in like Asian and Pacific Islanders. And when it comes to deaths, deaths from colorectal cancer can be almost 40% higher in Blacks than in whites. And so we know that although anyone can develop colorectal cancer, it seems to be a lot more prevalent in African Americans as far as the incidence and mortality.
Thank you. And that actually plays into my question for Ms. Duffin. In 2020, the world was stunned by the passing of the Black Panther actor Chadwick Boseman at 43. We later found out that he had been battling colorectal cancer since being diagnosed in 2016, being very much younger than a national average for screening. And so, as Dr. Winfrey just said, that Blacks are at an increased risk and are more susceptible. So why is this happening earlier than expected with our age group?
The research is beginning to show that there are a number of factors that are contributing to colorectal cancer being diagnosed in individuals, in particular African Americans, at a much younger age. And that includes everything from physical inactivity, our diet, our increased intake of processed foods, and those types of things. So we are seeing a significant increase in individuals under the age of 45, which is now the screening age, which it had been at 50. So we're very fortunate that they did reduce it to 45. But one of the things that we encourage individuals when we're providing education around colorectal cancer is understanding and knowing your body. as Dr. Clayton said earlier, and Dr. Donald said earlier about others symptoms that may present themselves, people need to be aware of changes in their bodily habits, especially their bowel movements, constipation or chronic diarrhea, different things like that. And so we try to encourage people to take personal responsibility for their health and educating them on paying attention to signs and symptoms. It may be minor, but if it's persistent, they definitely need to get it checked. And so a lot of times young people are often so busy and not necessarily paying attention to those things and have a tendency to be diagnosed at a much later stage. But again, a lot of the contributing factors to being diagnosed at a younger age, the research is showing that it's attributable to physical inactivity, obesity, and our diet, and as well as our family history. So we do encourage as well to know your family history. Know if you have a first-degree relative that was diagnosed with colon cancer or any type of cancer under the age of 50. And not only knowing that they were diagnosed and the type of cancer, but if at all possible, knowing the stage of disease at the time of diagnosis as well, because that will play a part in your treatment and your treatment outcomes.
Thank you. And so a portion of what you may have already answered, I'm going to roll to Dr. Donald. We in Louisiana, we love food and we love good food. And so can a person's lifestyle choices just affect whether or not that they develop colorectal cancer?
So this, again, we just got an excellent response from Renee. Absolutely, we know that obesity increases the risk of colorectal cancer. We know that there's data that red meat and processed foods also increase the risks for colorectal cancer. And you just talked about race, which I always have to say and remind everyone is a social construct. It is also associated, if you are Black or African American, with an increased rate or incidence of colorectal cancer. So yes, we know that we do have certain things that we are able to control as far as physical activity, as far as some of the things about our diet. But if we're talking about race being a social construct, we have to realize the inappropriate distribution of power that exists in this country that may lead someone to have a situation where they can't have organic foods or can't have fresh fruits and vegetables, as some of the more historically cheaper foods may be more processed and may lead to increased consumption that could then increase the risk. But at all costs, regardless, we have to know family history. We have to stay on top of our symptoms. We know that physical activity protects us not only from colorectal cancer, but several types of conditions. So physical activity, increasing that as much as possible, having a good balanced diet, and of course, knowing and sharing family history amongst the people you love.
Thank you. And so Dr. Clayton, what are some of those most common risk factors that are associated with colorectal cancer that a person should look for?
So Renee and Dr. Donald mentioned the lifestyle one. So lack of physical activity, increasing in age, low fiber diet, red meat consumption, obesity, alcohol, tobacco use, or the lifestyle risk factors. But then you also have, genetic predisposition. So you have, we have inflammatory bowel disease is a disorder that can increase your risk for colon cancer. We have some genetic syndromes such as familial adenomatous polyposis is one. And it's just a family history of colon cancer, and those patients develop colon cancer at a younger age. Family history, like we said, of colon cancer, family history of advanced polyps, which I explained in the previous question, is a precursor to colon cancer. Those are increased risk factors for colon cancer.
Thank you. And so, Dr. Winfrey, I know Dr. Donald touched on some of those social constructs, but can you expound a little more on the societal factors that affect this health disparity?
Absolutely. So we know, as Dr. Donald and Renee and Dr. Clayton mentioned earlier, that those lifestyle risk factors play a huge part in the disparities. Also, the lower socioeconomic group tend to have a higher, tend to be diagnosed with colorectal cancer at a much higher rate than higher socioeconomic status. We think that difference is related to those risk factors that were mentioned earlier. Also related to their access to healthcare and access to certain high quality screenings as well. And so there is a correlation between socioeconomic status, colorectal cancer, and then access to care, which is one of the reasons that as primary care providers, we really try to encourage patients to come in and have regular checkups with their providers to understand their risk. Because even though you may feel fine at the time, there still are risk factors that are present that you need to be aware of. I think Dr. Clayton mentioned it well earlier when she mentioned knowing your family history, not only of cancer, but of polyps, right? Because now that people are being diagnosed with polyps and maybe not being diagnosed with cancer, if you have a family history of polyps, that's important for you to know as well, so you can get screened also. And so those are just key things that having access to the healthcare system will help you to understand that and be able to navigate it for you and your family.
Thank you, thank you. And so, Dr. Donald, so what are some of the treatments that are available to treat colorectal cancer?
And just for the audience, I do want to say I've known Ms. Duffin for years, so I refer to her as Renee. but much respect to Ms. Duffin. That's a personal thing when I refer to her as Renee. As far as treatment options, the mainstay of most solid tumors would be surgical removal. We always want to be able to have those precancerous lesions or known cancerous invasive lesions removed surgically. There are instances, depending upon the location of that cancer within the colon, in which treatment with either radiation, which is energy that is focused to one area, or chemotherapy, classically chemicals that interfere with the growth of cancerous cells, that may be given before surgery in order to shrink it as much as possible and then have a better surgical outcome. And by surgical outcome, I mean being able to get all of the cancer. And then lastly, if the cancer is removed early, we can do, in certain instances, chemotherapy to reduce the chances of the recurrence of the colorectal cancer itself. And of course, if there are situations where the cancer has metastasized or spread to other parts of the body, chemotherapy can, in most instances, prolong life, given certain parameters of that patient's overall health status and their desires.
Thank you, thank you. And so, Dr. Clayton, should people wait until they notice the symptoms to be seen by a specialist, or, kind of give us a little, what should they do in that situation?
Absolutely not. We know that with colon cancer, especially for me, most of the cancers I find on colonoscopy are just absolutely incidental. Most patients are asymptomatic, so they don't have symptoms. Like Ms. Duffin said earlier, that you could have, some symptoms like bleeding from your colon, so rectal bleeding or abdominal pain and cramping, weight loss, unintentional weight loss, changes in your stool habits, constipation, or diarrhea. But that's only a small subset of patients. For the most part, patients are asymptomatic. So the whole purpose of this webinar and what we're trying to explain to the community is age 45, get screened for colon cancer, regardless of how you're feeling. Or if you have a family history of advanced polyps or colon cancer, please go to your primary care doctor and let them know so that you can get screened earlier than age 45 in some cases.
Thank you, thank you. You kind of just cut into my question for Ms. Duffin, but
Sorry.
I'm going to ask it anyway, because we've talked about, the family history, we've talked about the age of it, but so ideally, or not ideally, when should a person, really go get screened? Should this vary by socioeconomic status or age, race, or their location in the state or across the country?
So as Dr. Clayton said, absolutely not. At age 45, they should be seeking and consulting their physician, starting with someone like Dr. Winfrey as a primary care physician, having that discussion. If the physician is not having it with them, then they should be asking their physician, I'm 45 now, shouldn't I be getting a colonoscopy or having some type of colorectal cancer screening, and making sure that they follow up on that. Individuals have to begin to advocate for themselves. Physicians are very, very busy individuals. They see a number of patients per day. And so a lot of times they may not always, follow up, or they may not ask, but we have to begin to advocate for ourselves. And that's one of the things that research has shown, that a lot of African Americans do not advocate for themselves. I've read a number of different health literacy and cultural competency articles and reviews of literature that indicate that a lot of times when physicians are talking to people, the individual is sitting there and they're just kind of nodding their head yes, and the physician is taking that as that person, that patient is understanding what I'm saying to them as a physician, as a healthcare provider. But what they're actually doing is, I hear you, but I don't understand what you're saying to me. I'm acknowledging that you're talking, but I'm not acknowledging that I understand. And until we begin to ask questions and expect answers in layman's terms for individuals and advocate for ourselves, we're not going to get the necessary screenings that we need. And so that's one of the things as part of the education program at Mary Bird Perkins that we do, is help individuals learn how to advocate for themselves. And that's all a part of that taking personal responsibility for yourself. I'll share a quick story with you. Several years ago, when my mother had a stroke and was in the hospital, and her cardiologist came to see her, my niece, who was a cardiac nurse at the time, had equipped me with a number of different questions to ask the cardiologist. And so as I began to ask the questions, he looked at me and he was like, are you a nurse? And I said, well, what makes you think I'm not a doctor? And he goes, are you? And I'm like, no, I'm a daughter who cares about her mother. Please answer my questions. And so until we as individuals are empowered to be able to do that and not be afraid of the white coat, but view the white coat, being the physician, as our partner in our healthcare, we are not going to get to where we need to be as a race of people, as African Americans in this country. We have got to advocate for ourselves. And so we have to ask that physician at age 45, I need to be screened. What are my options? If I don't have health insurance, where can I go and get a take-home kit to do? Where should I be looking for that? Seeking out programs and services like we offer that will provide you with a no-cost kit. If you're uninsured and you have a positive kit from one of our screenings, we will help you get a colonoscopy for no cost, at no cost to you as an individual. But seeking out those services and advocating for yourself. I cannot stress that enough.
Absolutely. And so we have a question in the chat from one of our attendees, and I'm just going to throw it out there for whomever to touch on. The question is the FOBT a good screening tool for colorectal cancer?
I can take that. It can be a good tool if used correctly. There are a number of stool tests that are available. The guaiac-based stool test is one that is acceptable. The issue with that one is that it requires some dietary modifications before you administer it. And it also requires multiple samples to be taken in order to increase the accuracy as well. There are other stool-based tests that don't have the same requirements of dietary modifications or a number of specimens, but it is acceptable tests. The fecal occult blood test is one. There's another one's called FIT, or the immunochemical test. There's another stool test that's called a multi-targeted stool DNA test. Right, FOBT is guaiac fecal occult blood test, correct. And so all these are different types of stool-based testing for colorectal cancer. And if used appropriately and repeated in the recommended intervals, they can be effective as a screening test. What we like to recommend to our patients, or what we like to say to our patients, is the best screening test is the one that gets done. And so if the fecal occult blood test is the only test that's available to them, and they are willing to complete it according to the recommendations, yes, that is a great test to do, and we can start there.
Okay. Dr. Donald?
Dr. Anthony, I don't want to upset your program too much, but I have to go back to what Ms. Duffin said. And I tell people all the time, medicine is the service industry. No matter what, we're here to serve our fellow man. I have to say this over and over. I tell my family this constantly, and each time I walk into an examination room, I keep this in mind for myself. If you are not comfortable with the person assigned to manage your care, get a new doctor, period. You have the Dr. Winfrey's out there, you have the Dr. Clayton's out there. You can find the doctor who is able to answer your questions and to make you feel valued within that space. That I'm saying this as a physician. My time is not more valuable than your life. If you're afraid of taking up someone's time too much because you don't understand, you need to find someone with a better understanding of what the overall balance is within that room. I know if we're being honest and open, which I can't help but be, I know often that historically, people of lower socioeconomic status, as well as Black people in particular, have been felt to feel uncomfortable in certain spaces and to not occupy certain spaces. That's part of the inappropriate balance of resources and power. But the bottom line is we have to advocate for ourselves. Write your questions down, get a family member to write them down, be able to walk out of that informational exchange, which is a doctor's appointment, with the information you need for your life. Thank you.
Thank you. And so we've touched on family history, and we've touched on just the general screening ages. I'll say as a person with a family history of colorectal cancer and not being in that 45 age group, Ms. Duffin, what are the parameters around when a person should seek screening if they have a family history?
So in our program, and we do a screening risk assessment. Everyone at age 45 is at average risk of colorectal cancer. But with our screening risk assessment, which a lot of healthcare providers use, they will ask those additional questions. Do you have a family history? Is it a first degree relative? Do you have a family history of polyps? And if you do, we will provide a FIT test, which is what we administer in our community screenings. We will administer a FIT test to an individual under the age of 45 because they're of their family history or family history of polyps, or if they're symptomatic, then they are at average risk of colon cancer. And so we will go ahead and give them a test at that time.
Thank you. And so, Dr. Clayton, feel free.
And I just want to say also too, if you have a family history of colon cancer and the person is, younger than 45 or younger than 50, we usually start screening them with colonoscopies 10 years younger than the person that was diagnosed with the colon cancer, or age 40, whichever one comes first.
Thank you. And so with that, I'll kick one of our final questions to Dr. Winfrey. Is screening for colorectal cancer expensive?
That's a great question. It can be, but it doesn't have to be. And so, again, I think Ms. Duffin mentioned earlier that there are programs out there that allow you to get access to screening tests at no cost or very low cost. And so it doesn't have to be. Also in sectors like we're in, where you have access to public hospitals, where individuals who fall below a certain income range will qualify for free care or reduced care at certain hospitals. It doesn't have to be. Even a colonoscopy doesn't have to be very expensive. And so it can be, depending on where you seek out your screening test, but it doesn't have to be. And so that's where being an advocate for your care is important. And then knowing some of the avenues out there where you can get screened. I think Ms. Duffin has touched on it very well earlier about access to care, access and the tests they have available. There are community health centers in just about every parish and community throughout Louisiana. And so if you're not sure where to start and cost is an issue, check in with one of the community health centers in your area, and they'll be able to help you navigate the system as well.
Thank you. And so a question from the chat. Suppose I get a stool test and there's an issue where it comes back positive. Will I have to pay a copay to get a follow-up screening from that? And so whomever feels most comfortable answering it.
I will say that a lot of that is contingent upon your health insurance provider. And so, that's typically something that you have to work out with your insurance carrier to resolve that.
Okay, and so generally with screenings, so if a person has, just say if they take a stool-based test and it comes back positive, and from there a colonoscopy is necessary, generally are those screenings considered screening still, or is it diagnostic at that point?
It's diagnostic because they now have a positive test, and that can be a positive Cologuard test. When we go to do our colonoscopy, it changes to diagnostic because it's telling us something is actively going on in the colon. Sometimes these tests do have false positive results, but for the most part, it's telling us that something's going on in the colon. So the billing code changes to diagnostic.
Gotcha. Okay. Thanks for that clarification. So as we close, I want each of you to answer this question. What is the one thing that you want our audience to take away from this webinar? And are there any services that you would like to shout out related to colorectal cancer or awareness that we have not touched on? And we can start with Dr. Clayton.
So I just want everyone to know that colon cancer is very, very, very preventable. And come and see me for colonoscopy. It's not scary. You do get sedation. It's the gold standard because, it's both diagnostic and therapeutic. But, if you're still not there, you have Dr. Winfrey here and other primary care doctors that can offer you other screening modalities. And we really, really want you to come out and get screened to prevent colon cancer.
Okay, that same question, Ms. Duffin.
The one thing that I would echo what Dr. Clayton said is to get screened first and foremost, whatever type of modality you choose. The day before the colonoscopy is absolutely worse than a colonoscopy itself. Trust me, I know. But what I will say is take personal responsibility for your health, know your body, increase your physical activity, improve your diet, access to fresh fruits and organic fruits and vegetables and things like that may not be, easily accessible. But let's try to stay away from the fast food and the highly processed foods. If you can't get fresh, get frozen, those types of things, making some changes in that diet, eliminating tobacco, all of those things that increase your risk. And no matter where you fall on the socioeconomic scale, there are services that are available to you. At Maryborough Perkins Cancer Center, throughout 30 parishes in Louisiana, 18 in Southeast Louisiana, 12 up in Northeast Louisiana, through the use of our mobile medical clinics, we offer no-cost cancer screenings for 5 different types of cancers, including colorectal cancer. It is a take-home kit that you self-administer. If you have a positive finding and you do not have health insurance, we will assist you in getting a colonoscopy in your local community. We're able to do this through the generosity of philanthropy from the community and grants and donations. And so we do encourage you to go to our website, www.marybird.org, and see where we're going to be in your area. Come by our mobile clinic and get a kit. Get educated. We may have our inflatable colon out there where we can show you very graphically what polyps look like, what a malignancy will look like, and those types of things. The other thing I encourage you is to be compliant with getting rescreened. It's not a one and done. If Dr. Clayton in that gold standard colonoscopy finds polyps and she tells you you have to come back in 3 years and have it repeated, or 5 years and have it repeated, then you need to go back, put it on your calendar, and go back and get it repeated, because you may have additional polyps grow. If you don't find any polyps and they tell you to come back in 10 years, consider taking a FIT test in that 10-year period, or another take-home test during that time period, just to make sure, especially as we get older. So being compliant with that regular routine schedule for screening is just as important as getting screened that first time. But remember, it's not one and done, and we have to be compliant and we have to take responsibility for our health.
Thank you. And so Dr. Donald, that same question.
I think this is a wonderful panel. I'm so happy to be here. All the information shared is all the things that I would want relayed to everyone. But there's a saying that faith without works is dead. And so often we hope for things, but we don't necessarily do all that we can on our end to achieve that result. And we do it in other realms. We look both ways before crossing the street. We don't walk in the woods in the dark. We check the date on the milk before we drink it. We do all of these things to stay careful. So sort of putting our heads in the sand about colorectal screening or any other type of screening just doesn't serve us well. And I think all of us benefit from advocating for ourselves. That's part one, by actually showing up. That's half the battle. But number two, holding that healthcare provider accountable. I can't say this enough because it's not said enough. We need to feel comfortable with the people managing and dictating our care. There are stellar physicians from every stripe of life that care for people, stellar nurses, stellar social workers, all working together. Seek those persons out. I would like to, if I could just end saying, give a shout out to the community health centers throughout Louisiana that provide stellar care in a way that is comfortable to so many Louisianans. So don't hesitate to seek the care from one of those facilities.
And Dr. Winfrey, that same question.
Yeah, I think the main take-home points I would have is one, that colorectal cancer can be prevented. And that's the thing that really needs to resonate, because Dr. Clayton mentioned, Secretary Phillips mentioned earlier, just how the rate of colorectal cancer is like the second leading cause of cancer in the United States. And so it doesn't have to be, right? It can be prevented. And the way to prevent it is what we've talked about here, is knowing your risk factors, getting screened, and staying in touch with your healthcare provider. Again, the saying we have here is the best test is the one that gets done. I encourage all of my patients to get the colonoscopy when they can. That's one of those visual examinations. Nothing beats looking directly inside the colon and identifying something that looks suspicious. You can't beat that. But I know a lot of people are just a little hesitant to go there and aren't quite ready. And as a matter of fact, the whole conversation around colorectal cancer is just not one that people want to have. They don't want to talk about cancer. They don't want to talk about the colon. They don't want to talk about stool. Like, there's nothing about the conversation that anyone wants to have. But what we do know is that that's the second leading cause of cancer death. So we have to have the conversation. And so we can't wait till you have symptoms. You can't wait till you don't feel well. You can't wait till you hear somebody else in the family has it. It's important to understand the risk factors, understand how important it is that we go in and get screened. So The two take home, I know you said one, but the two take home points, colorectal cancer can be prevented. And two, the best test is the one that gets done.
Great, great. So thank all of you. I'm honored to have moderated this discussion with such prestigious subject matter experts. But before we leave, my part is done, but I'm going to kick it back to Ms. Brown. She has one last question for y'all.
Yes, thank you, Dr. Anthony. And I agree with you. This panel has been so informative. I'll tell you this, is that the question that I have is probably the one thing that I think I wish I would have known. I think I knew the importance and I was ready and knowing that I needed to get tested, once I made 45. But what I didn't know going in is what it even looked like, right? So I think Ms. Duffin, you alluded to it earlier, the discomfort the night before is probably the worst of it. But Dr. Clayton, if you can just even explain, because I think that was one of my main concerns. And I hear a lot of people saying, man, I don't even know what it looks like. I thought I was going to be awake. I thought it was going to be a totally different experience than it was. And if you kind of can explain the process of a colonoscopy, because I think you were the one that said it's the gold standard of testing. And so it would be really great if the audience can hear what would that look like if they came to you or anyone for a colonoscopy.
Okay, so we'll start with the day before, like Ms. Duffin alluded to. The day before, we give you a bowel preparation, and that can be a liquid, and now we just develop pills that you can take. And the purpose of that bowel preparation is to purge you, essentially. So the day before, you're on a clear liquid diet all day, and then you get the bowel preparation that afternoon around 6 p.m. or so. And the purpose of that preparation is to clean your colon. So you are having multiple bowel movements for the remainder of the day. Still not that bad, guys. So you have multiple bowel movements for the remainder of the day. And the purpose of cleaning out your colon, because for a colonoscopy, we need your colon to be cleared and pristine so that we can see every surface, every bump, everything, so that we can identify a polyp, which is an abnormal growth in your colon, from just the normal lining of the colon. And so then the next day, which is the day of the procedure, you come in and you're set up, you change your clothes, you get an IV in, and you go to the procedure room. In the procedure room, there's a nurse, there's the doctor, and there's usually a nurse anesthetist that's going to administer anesthesia. So you are not awake at all during this procedure. And I tell my patients all the time, you're not awake, you won't feel a thing, you won't remember a thing. And so the worst part of the procedure is actually the day before, because we're kind of making you have diarrhea all night. But the day of the procedure, there is no discomfort. And so now I work at a hospital, and most surgical centers or so are using propofol as the anesthetic. And so patients love that, because they're like, man, I had the best 8 hours of sleep, even though it's really only a 20-minute procedure. So you're getting that, you're getting anesthesia, and you're sleeping. And while I'm there, like I said, I'm looking at your entire colon, and I'm looking for polyps. And if they are present, we have different modalities to remove them, and we remove them to prevent colon cancer. And then once you awake, you wake from the anesthetic, you feel fine. There's no more issue, there's no discomfort, nothing, and you're able to return to normal activities and work the next day.
Thank you. I think that was so helpful. I didn't get all that explanation. It was just like, show up. I think because I was so, affirmed that I needed to do it, that it was just show up, and I did. And so it's great to hear that explanation. I'm pretty sure that our audience is appreciative of it, as I'm sure they're appreciative of all of the information that you all shared tonight. So thank y'all all so much. I'm going to turn it over to Ayana to close us out for the evening.
Okay, wonderful. Thank you, Dr. Clayton, Ms. Duffin, Dr. Winfrey, Dr. Donald, and Dr. Anthony for your responses and for being a part of this especially important panel discussion. As community gatekeepers and medical providers participating in this discussion, each of you has helped to enrich people, populations, and communities' awareness. So thank you. All right, so bringing back up these key takeaways from today's discussion. And again, what a wonderful panel discussion we had. So again, reiterating that in getting information, so getting up-to-date and accurate information from credible sources related to colorectal cancer, screening, so everyone between ages 45 and 75 especially should get screened for colorectal cancer. Prevention, understanding what colorectal cancer is, the screening recommendations and risk factors associated with colorectal cancer, all which was discussed today. And then last but not least, again, understanding that early detection truly does save lives. All right, and most importantly, I want to thank all of our attendees for coming and listening to this discussion today. And I hope that you found something enriching and valuable that you can take back and add to your discussions with your families and within communities. Please utilize the resources that we will be emailing to you after today's presentation, including the recording of this webinar and our one-pager, which outlines the facts regarding colorectal cancer, the information related to it, as well as resources that are available within the state of Louisiana. And at this time, I will bring back on the Director of the Bureau of Community Partnerships and Health Equity once more to close out our webinar. Devondra.
Yes, thanks, Ayana, and thank you to everyone who participated tonight, who attended tonight, and of course, all of our panelists for being present. I'd like to thank the staff of the Bureau of Community Partnerships and Health Equity and the Bureau of Media and Communications for executing such a needed conversation. A huge thanks goes to the entire Louisiana Department of Health team. And last but certainly not least, a special thank you to the Secretary of the Department of Health, Dr. Courtney Ann Phillips, for her continued leadership in pursuing a healthier Louisiana. Please join us for our next conversation focusing on minority health on April 20th at 5 p.m. You can use the QR code on your screen, or you can go to tinyurl.com/LDH Minority Health Web to register for our next webinar. This will include today's event. Thank you all and good night.